we're hearing about patients in their late 30s and early 40s being diagnosed with stage 3 colon cancer. I mean, it's not going away, the need for colonoscopy. And so we need to support the people and the infrastructure that are really performing this procedure. And, we feel strongly that ColoWrap can play a big role in that. So.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
On this vendor spotlight on First Case, Melanie and I speak with James Hathorne, CEO and founder at ColoWrap. We're going to be talking about a new solution to an age-old problem in GI, and it's an anti-looping compression device. Melanie, you got to see this firsthand at AORN.
I did. I actually got it put on me and got to experience how it fit, how it felt, and get to see how it worked. But you mentioned an age-old problem. Scope looping, when we are doing colonoscopies, is the primary barrier to safe and efficient colonoscopy procedures. And so having an anti-looping device that's designed for the patient to help their procedure go smoothly and quickly, and also a device that also protects the staff from all the pressure injuries that could be caused. I mean, it's just a lot of good things in an anti-looping compression device. And I'm excited to hear James talk about the design and the thought process and the research and everything that went into this device.
It's also a human interest story. It's a family business. Stay with us. James is going to be telling us all about that in just a few minutes. We'll be right back.
From the studios of Healthcare HQ, you're listening to First Case.
Today, we have the pleasure of speaking with James Hathorne, CEO and founder at ColoWrap, and we're going to be talking about their anti-looping compression device, which, Melanie, you got to see, I believe, at a conference not so long ago. So, not only are we talking about something we've heard about, we're talking about something you've actually had a chance to see. And so, James, I want to welcome you to the First Case podcast, and thanks for coming on today.
It's a pleasure to be here. Really appreciate the opportunity to chat with you all. The stuff that we've listened to from your podcast before has been not only super informative, but great energy. And so we feel lucky to have the opportunity to chat.
Well, I can tell everybody that doesn't know yet, and they're about to find out, you've got great energy and passion for what you do as well. And so I've been excited for this podcast since we first had a chance to kind of talk and hear a lot about the background of the company too, and your role as a CEO and founder. But can you talk a little bit about your background? I'm going to have you talk about the company too, and maybe these conversations kind of blend into one story, but it is a unique one and it's super interesting.
Sure. I mean, just a couple of points for my background. Like, I'm probably not very employable. Like, my mom fired me from her first job at her office within like 2 days. So that was a good lesson that, maybe at some point in my life would need to take maybe an alternative path. So I grew up in a household with both my parents were physicians. Mom's gastroenterologist and dad's oncologist. And so kind of almost like growing up in a bilingual household, you're kind of through osmosis, always hearing and learning. And I think that definitely played a role in kind of where I am now. And then, by way of education. So I'm from North Carolina, grew up in Durham. I went to Duke University. So I'm a big Duke fan. And then I was at the University of Colorado Boulder, where I did a JD and MBA degree. And I think it was really just trying to, having kind of entrepreneurial spirit that I maybe at the time didn't really recognize, but wanting to have a little bit of structure to the way I kind of thought about business. And so it was a neat way to get that experience. And, while I was there, I had the opportunity to be involved with something called the Deming Center Venture Fund, which is a little venture fund attached to the endowment And so, got to experience and be around entrepreneurs and new technology. And I found myself much more attracted to kind of sitting on the other side of the table. Right. And so I ended up back in North Carolina. And it was at that time that, my mom was in practice and dealing with an issue, which essentially became the origin story of the company. So I'm not sure if that answers the question.
I mean, we're definitely going to dive into that. You didn't tell us the first time about your early exposure to entrepreneurs. And I think that that's just wonderful inspiration for anybody. I mean, I didn't realize that I had an entrepreneurial spirit until well into my 30s. And so, I think I think a lot of people should get that exposure because it does kind of give you the sense that there's limitless possibilities. And it's a lot about figuring out something that you're passionate about, that you enjoy doing. And especially for those that are self-driven. And to your point about not being employable, there are certain people that are just, they're meant to be decision makers. And when they don't have decision making ability, they feel stifled. And I think for those people, it's important for them to figure that out about themselves before they have to support a family.
Yeah, 100%. I mean, and I think people think about entrepreneurship and risk, and certainly those are real considerations. But the one takeaway that I always like to say is it's also very difficult to compete with passion. So if you can find something that you're both passionate about and that, other folks, other customers find a value, I mean, that's de-risking in and of itself.
Yeah.
Absolutely.
All right. So walk us into the company then, because obviously this
is that origin story.
Yeah.
So my mom is, I would say, probably among the top 2 or 3 most influential people in my life. Phenomenal physician, just completely relatable to her patients, but was also an excellent endoscopist. She was also the only female endoscopist, gastroenterologist in her practice of 7 males. And so what that meant practically was that a large portion of her patient population were female patients. Now, you all probably know this, but just for the origin story, female patients tend to be a little bit more challenging to perform colonoscopy due to greater colon length relative to their body size. You also have, hysterectomies and post-surgical adhesions. So she had a larger percentage of patients that were difficult. And as a result, due to what, it's commonly known as kind of the manual pressure and repositioning and the way difficult colonoscopies are managed, she had 2 of her nurses that had suffered injuries, 2 of her long-term nurses, as a result of putting on manual pressure on these patients. And she herself ended up suffering an injury that ended her career that she attributed in part to the years of scoping and torquing. And, what we came to find out is that these types of things are not necessarily uncommon in people that are doing a lot of colonoscopy. And so the origin story was essentially hey, this is kind of crazy. This is kind of barbaric that this is we have these $50,000 scopes and this phenomenal technology, and we're still doing WWF moves to get the scope to the sequence. Right. And so at the time, my brother John, who's also with the company now, he's our COO, he was at NC State, and they had a neat intersection between the great textile program and entrepreneurship. And he had a project at the time where he had to basically go out and find a real problem and come up with some solutions. And so it was just kind of serendipity, the timing, where my mom was like, hey, I have a problem. Right. And it was this idea of, in these colonoscopies where, it's challenging to get to the cecum and you have looping, you have these people given manual pressure. They're getting hurt. I'm getting hurt. There's got to be an alternative that can help complete these procedures in a safer way. So that was kind of the problem identification. And then from that point forward, the seeking the solution was essentially, well, how can we replicate what is being done by hand in a way that's safe for the patient, that's cost effective, and that actually helps get the scope to the cecum. And that was kind of where we started experimenting with different textiles and mechanisms to apply non-manual external pressure to support colonoscopy.
So you've whetted my appetite just a little bit, and
I
really
that's interesting. I want to know what you eat for dinner if that's what gets you.
Yeah, right. Got all talking about colonoscopies and getting excited, right? But colonoscopies are new for me. I've been in the operating room for many, many years, and then this latest facility that I work at now, I also have to cover endoscopy. And the idea was just, you can work in the OR. Of course you can work in endo. Just go,
sure.
Go to the butt hut and go get going. Sorry, maybe if we don't want to say that, but that's, what it's affectionately called in a lot of places.
That's hilarious. That's great.
And, but we're not taught anything other than, okay, you need to get this. Here's where you hook up the suction. Here's the poly trap or all this stuff. And here's how you chart. And then all of a sudden it's like, oh, hey, I need some pressure. And I'm like,
Right.
what? Why?
Yeah.
I don't even know. I don't even know what I'm doing. But before we kind of get into those reasons, and the injury that it can cause, can we take a step back maybe and talk a little bit more about why it would even be difficult to get a scope to the cecum in the first place?
Absolutely. First and foremost, I want to do the PSA, and that is colonoscopy is the gold standard screening procedure for colorectal cancer. And it's the gold standard for a reason, right? It's the only diagnostic and therapeutic combined procedure. It is highly, highly effective at reducing colorectal cancer. So I encourage everybody to go get one that needs one. I'm 39 and I want to get one when I turn 40. So first and foremost, nothing I say is meant to deter anybody from getting colonoscopy, right? That being said, a lot of people don't realize that it's a challenging procedure to perform, and it really has to do with the anatomy and the mobility of the anatomy. So if you think of the colon, it's almost like a floppy sock. And the goal of colonoscopy is to insert the scope and advance the tip all the way around to the end of the large intestine called the cecum. And really the examination of the intestinal wall and the colon is done as they withdraw and pull the scope out. But you got to get it there first. And so what you're trying to do is you're trying to push this flexible scope through this floppy sock. And as the doctor is pushing more scope in the body, instead of the tip advancing nicely through the pipe as if it were a fixed pipe, the pipe's moving, right? The pipe's stretching, the pipe's twisting, and the tip is not advancing. It's sometimes going backwards despite more scope going in the body. It's so if you can imagine trying to get a hose from one side of your house to the other, when you get to that corner, the hose is going to keep going straight. It's not going to naturally kind of make that turn. And so as a result, what is being done from a physics standpoint when someone's putting their fist or their arm into your abdomen is they're creating counter pressure so that when the doctor pushes the scope, it pushes against that arm or that source of pressure and it pushes the scope forward. So it kind of holds things in place. So you're trying to fixate the anatomy in order for the push force to advance the scope forward. And so that's essentially what is being done when asking for pressure. What they're trying to say is, hey, somewhere in this abdomen, the bowel is stretching and not allowing the scope to move forward. So I need you to figure out where it is, even though you can't see it.
Yeah.
And I need you to push on it at some level.
Blindly, and just smash away.
Let's just see if it works.
Right.
And, the way you see if it works from the endoscopist's perspective is they get one-to-one advancement. So when they push the scope, they see on the screen, okay, now the tip's advancing. But it's not a science by any means. I mean, there was a study that was really interesting that was done a while back, but where they used magnetic imaging so they could actually see what was going on in the abdomen, but they blinded the doctor to it and the staff. And so when they said, okay, the doctor would ask for pressure and they would say, okay, where do you think that the loop's forming, doctor? And they would guess, and it was incorrect 2/3 of the time. So they were saying push at the sigmoid and it was in the transverse or vice versa. It's an inexact science. And I think that would be one thing, but it's also kind of variably effective. And, what we came to find out as we had these experiences, and my mom and her staff, is that there's some real safety concerns with it that really kind of call into question it being kind of the status quo for how to support colonoscopy.
For sure. And scope looping actually is really common, isn't it?
100%, because it's a function of the anatomy. I mean, there's been tons of really technologically advanced innovations with the scope, stiffening wires and over tubes and really neat stuff technologically. The challenge though is the only thing that's controlling for is scope stiffness and scope orientation. You're not controlling for the anatomy. So even if you do all those things, if the bowel and the anatomy is still mobile and moving, you're still going to kind of run into the same problem. And so that's where, with respect to ColoWrap, where, our solution is kind of different, because what it's solving for is the anatomy. We're saying, okay, if we can just get the anatomy in place, this may not be a perfectly easy case, but it's going to be dramatically easier for you to get the scope where you needed to get it.
Yeah. And I like dramatically easier as a staff member who has been 100%. On the side of that stretcher, bent 100%. Over at a weird angle, smashing away. And really, okay, as nurses, anybody here who is in the audience listening, if you have been on that side of the stretcher, having to be the one applying pressure, I mean, sometimes you can kind of see where the scope is, depending on the size of the patient. You can kind of guess, but you can't always. And even then, what are you pushing on? 100%. What are you putting pressure on? And are you causing further pain, damage, or anything to the patient beyond what you're doing to help past the scope, right? So if we think about that and what staff are required to do in endoscopies and those risks of injuries to the staff, what are those common injuries that you've seen from staff reporting pain or injuries after endoscopies?
I mean, widespread incidents of pain first and foremost. So we've done some research. We had a survey at a SGNA conference where there were 220 nurses that participated. And we asked, are you responsible? Is this a task that you are responsible for? So of the 220, I think 120, essentially raised their hand and said, or fill out the form and said, yeah, we are. And of that 120, like 85% had experienced some musculoskeletal pain that they were confident was directly related to this problem. There are a couple other studies that have looked at it and found like the rates of, missing work due to pain and injury in endoscopy nurses is like 30%. 14% of endoscopy nurses have had some type of musculoskeletal surgery due to work-related issues. We have a couple folks that have joined our team, nurses that work with hospitals adopting ColoWrap, and they have scars on their wrist from surgeries that they've gotten as a result of their time in endoscopy. So these are real impacts. We did some research where we actually measured the forces that were required when somebody is pushing and holding manual pressure. And it was, it goes up with patient weight, but for a heavy patient, it can be over 100 foot-pounds of force. So to put that into context, kind of in the scope of the problem, anywhere from, a third to more than half of patients where, pressure is being required. If someone's holding pressure for 4 minutes, that's the equivalent of pushing that same patient in a bed over a half mile.
Wow. It seems more real when you put it into that kind of a perspective, because you don't think about just pushing onto somebody's abdomen, while you're, let them moving the scope around. But then you think about turning that same amount of pressure, enough pressure to push a stretcher, and to push a stretcher for half a mile. That's significant. So obviously we have a lot of injuries to staff from sustained pressure and sustained injuries over that. But then what about the patient? Because they're the ones on the receiving end of that pressure.
100%. Yeah. And it's another thing that's really interesting. I mean, a number of hospitals that we work with will say things like it doesn't really show up in any kind of reportable statistic, but we'll hear things like, yeah, we had a patient yesterday come back with a perfectly formed handprint bruise on their abdomen. And they were kind of asking like, well, what happened? Or patients that say, I have some abdominal pain after the procedure. I mean, a lot of people think, maybe that's gas, but that's even after they've switched to CO2 and they're still having these issues. In rare cases, and I'm not sure if maybe Connie mentioned this, but you have splenic ruptures that are
We did talk about splenic ruptures, right. Yes.
Which is a life-threatening complication.
Yeah.
It's a life-threatening complication, right?
Oh my gosh. And so when Connie was talking, she made a very good point that when she teaches her nurses about manual pressure and the things that we do, she's like, can you palpate a spleen? Do you know where it is? And a lot of nurses, we don't necessarily do that in assessment in nursing school. Hands up. I certainly have to go look it up. Oh, where is it? Okay, let me make sure. So if you're thinking about all the organs in the abdomen and whatever you're doing, or risk to the diaphragm even, or any other things that you might damage while you're smashing away, our patients can have significant side effects after the procedure that have absolutely nothing to do with the colonoscopy itself.
Yeah. And it's something that's actually recently emerged, which is really interesting. And is, there are a lot of patients that are having colonoscopy that are on GLPs. And, the current recommendations are to stop the GLP-1s 7 days before the procedure. But I saw some data from actually a hospital we're working with where they were doing upper endoscopy, and they found that 25% of the patients that were on GLP-1s that had stopped, according to the guidelines, still had retained gastric content. Well, what do you think happens if you take a fist and you put that fist into the stomach? Well, that's going to come up. And so I've talked to a couple of anesthesiologists that have felt like there's kind of a unique risk with respect to manual pressure due to the fact that more patients are coming with stuff in their stomach and a greater risk for aspiration. So another reason why kind of I think considering alternatives to that kind of very direct or specific or high force manual pressure to complete the colon is probably warranted.
Yeah, absolutely. And the other thing that comes to mind before we move on in our conversation, but, we always have at least most of the surgeons I've worked with doing colonoscopies, they might want you to do pressure. They might want you to start smashing, but they might just reposition instead. And so we're flipping this patient from their side to their back while they're kind of out of it. And you're keeping the camera plugged in plugged in.
Right.
You know what I mean? You're keeping that camera in while you're trying to roll them over. But when you're thinking about repositioning versus applying pressure, are there any other risks or things that we maybe should be thinking about when we're repositioning those patients too?
I mean, in my experience, the anesthesia providers are not super happy when you have to take the patient and put them on their stomach, right? So there's that generally. But then from an ergonomic risk to staff, there are thresholds that the ARN has actually established for what's considered safe. And for one person to reposition a patient any greater than 115 pounds is considered like beyond the safety threshold. So many of the patients that we see are a little bit heavier than 115 pounds.
Yeah, just a little bit. Just a little bit.
Yeah. I mean, and I think that it's been in our experience working with various hospitals, you see things that are just established as kind of common practice. And so we've seen things like, on the pressure side, like the Superman, which would be then they rolling the bed against the wall, and then somebody puts both feet against the wall and both hands in the patient and is completely horizontal applying pressure.
Oh my gosh.
Yeah. Yeah. I've seen the rotisserie, which is multiple flipping of the patient back and forth.
Oh my.
Kind of common practice. So, I'm not saying any of these things to imply that there's any intent to do harm. I mean, they're trying to do
they just don't have a better solution.
No,
that's their solution.
Yeah. And it's important to get the scope to the cecum. I mean, the right side of the colon is really important to inspect. And I think so it's all towards a good end, but it can kind of be shocking that's what's going on.
Seriously, nobody else try to solve this problem?
I think that there's lots of people that have tried to solve it, and with good kind of commonplace solutions. The challenge is just trying to achieve kind of standardization, where you have a tool that works for most patients, if not all, and that can kind of easily be taught and trained, as opposed to kind of being unique to one location, or we roll up a towel, or here's a football, or and there's some safety issues with some of these things. I mean, I think that as a result of our efforts to build a company around this, I mean, there are requirements that we have to go through to make sure that what we're delivering is safe and consistent, and we educate the people using it. So I think that's probably the difference.
Yeah, that's great. And I know sometimes how hard it can be to get through regulatory. So that's exciting to hear. Why, before we go much further, why don't you just describe how you use it? Like, tell us exactly, what that looks like in the day-to-day operations of anybody working, in endoscopy.
Yeah, sure. I mean, so the device is most easily applied prior to the case. And so it does require some thoughtfulness about which patients to use it on, but really how it works and kind of how it's different than other things that have existed in the past. It has two components. It's got the primary band and then two secondary straps. And so the primary band is applied when the patient's in the supine position, and it's applied tightly. And what differentiates the product from, like, some people will say, oh, well, this is like a binder, or we've used a towel in the past or a football, but the material of the primary band, it's designed like a wetsuit. And so it stretches horizontally, but not vertically. And when it's tightened, and particularly when the patient lays on their left side, it stays flat against the abdomen, and it actually creates some concavity. And that's really important, because what we found in testing, when I think people that have tried binders or surgical girdles and things like that, is often they'll roll up. And once they roll up, they cease to kind of splint the colon and can actually kind of cinch the lumen. So that was kind of a design goal that was important when we were developing it. And the other element is there's these two secondary straps, and they're designed to be adjusted just as like two hands can be adjusted during the case. So they can target different areas of the abdomen, like the sigmoid colon or the transverse colon, kind of on an iterative basis to help get the scope in and around.
So you basically, depending on the procedure you're going to be doing, you apply accordingly. How long does it take? I'm kind of thinking of this and like, oh, that could take a little while to kind of get everything situated. How long is the process?
No, it's very easy. Yeah, it's very easy. It takes probably, once people are up to speed, probably 10 seconds, 10 or 15 seconds to apply. And then, the adjustment during the procedure is really easy. So I think that's definitely, if we think about what are the elements of ColoWrap that's made it At this point, honestly, the most widely deployed anti-looping tool ever, which is kind of a neat thing to say. It's been used in over 100,000 colonoscopies. I think it's a safety profile, its effectiveness, and its ease of use. Those are the three things that really make it stand out.
Okay, James, I know that I saw this product at the AORN Expo, but everybody is not visualizing this like I am. And you mentioned that it only takes a few seconds to put this thing on, but what does it really look like, and when are they supposed to be putting it on the patient?
So I think in my memory, we actually had you up on the table, didn't I? We may have put it on. So that's what I'm visualizing right now. So, to reference what that actually looks like. So the device is generally applied. It can be put under and behind the patient in pre-op, but it's typically applied tightened just prior to sedation in the procedure room. And really what it consists of, the easiest way to describe it is people think of kind of an abdominal wrap or a belly band or a belt. It wraps around the back of the body and adheres around the abdomen. So it's like an abdominal wrap, colo wrap, but it's the material. So the material is tightened, and that's the primary band. And then it has these two secondary straps on it that are anchored right at the patient's left hip. And so what happens is the device is applied while the patient's flat on their back. The patient turns to their left side for the procedure. Sedation starts. The procedure begins. And in the procedure position, the two straps are accessible and can be, moved and stretched across the abdomen. So just as needed.
Yeah.
Right.
Just as needed. And I think it's important what you hit on, how the size of it and where the colo wrap is actually applied, because a lot of us probably think back to our abdominal binders that we're used to seeing in surgery. And it's not the same width as that abdominal binder that, like you said, is going to roll up and cause pressure and all that stuff. It's longer, and it's actually fitting that torso. And so having it in the right place where it's not going to move around, so you can pull those bands and tighten as you need to, it's designed effectively to stay in place and to provide that pressure. And I think that's really good.
Yeah. And I think that when we teach particularly in places that have tried abdominal binders in the past, like the tendency is to put the device too high up on the body, right? Whereas like to keep your generally for colonoscopy, if you can keep that sigmoid colon in place, that's 70% of the deal. 70% of looping is in the sigmoid. And so the colo wrap's actually positioned fairly low. So the top of the primary band is generally at or near the iliac crest. So it's often lower than people think, and it needs to be on quite snug. And so the actual device has a mechanism where two of the nurses kind of pull on opposite ends, which gets it really snug and holds it in place. And then again, the secondary bands are not tightened to start the procedure, but they're there to be adjusted.
And so then we've got the patient in the room. We've got the bands tightened as we need to. And you said like the majority of the issues are, in the sigmoid as we're advancing the scope, but we've got to get to the cecum, right? So when the patient has the colo wrap applied, the surgeon's inserting the camera and doing the procedure, how much time is saved when a patient is wearing a colo wrap?
So the average time, if you look across colonoscopies, it takes to get from insertion of the scope to the cecum, it's called cecal innovation time. It varies. It's anywhere between kind of 6 and 12 minutes on average, depending on who's doing it, how often they do it, and also patient anatomy plays a huge role. Some difficult colonoscopies, a difficult colonoscopy is generally considered a cecal innovation time over 10 minutes. On average, colo wrap is going to save 20 to 30%, so 2 to 3 to 4 minutes reduction in cecal innovation time. But for cases, if you look at the distribution of cecal innovation times, about 1 in 10 to 1 in 8 colonoscopies have a lot longer. They're like 10, 15, 20, 30 minutes, considered difficult colonoscopies. And in those cases, colo wrap will often cut that cecal innovation time in half, which can be a big time savings.
Oh, for sure. Absolutely.
And some of those patients present with prior, they know that they've had a prior difficult or incomplete case, and those are great candidates for the product. Colonoscopy, as a general rule, tends to be more difficult on patients at either the low or high ends of the BMI spectrum. There's almost kind of like a Goldilocks effect, and it has a lot to do with the visceral adipose tissue volume. So for people that do a lot of colonoscopy, they can often kind of look at the patient and kind of go, this one could be tough. Right. And it really tends to concentrate, interestingly. On the heavy side of patients, like when interventions are needed, it's really challenging. You can't reach the cecum. It's really tough on the staff. And then interesting on the lower end, and particularly in older patients that have less visceral adipose tissue, less tone, they can be really challenging as well because they just have a lot of tortuosity in the colon. And in each of those patient populations, ColoWrap is really effective.
That was my last patient I had to apply pressure to. It was this little old lady who was itty bitty. And I'm sitting here going, why am I having to put pressure on this small patient? Because I didn't know that actually not having enough adipose tissue could actually make it just as difficult as some of our larger patients. But yeah, I was putting a lot of pressure on her lower abdomen so that they could advance the scope. And I did not realize that there was actually a reason for why our smaller patients could be challenging.
Sure. And those are the patients I think that you really think about, wow, like, am I pushing through the patient's body? I mean, there's just not a lot of tissue. Am I hurting them? Right. And yet at the same time, there can be really, really challenging patients to scope. I had a surgeon say to me once, and this really kind of made sense to me. The most difficult patients to scope are the easiest patients to perform colectomies on because there's so much redundant bowel that if they had to cut a portion of it out, they just take it out and reconnect. Well,
I can see that.
Those are the patients that are really difficult to perform colonoscopy because you're trying to basically pleat all of that bowel in the scope.
Go through all of it. Yeah.
Yeah.
Wow.
All right. So you talked about the reduction in time, but we've also discussed, really what this means for the nurses that are assisting and the ergonomic maybe considerations or implications really that lead to injuries. So, what about how have you measured the impact of that on the staff?
Yeah. So we've looked at that in numerous clinical studies. So in one randomized control trial, use of ColoWrap resulted in an 85% reduction of nurse-reported musculoskeletal pain associated with supporting colonoscopy. In another study done at Barnes-Jewish West County Hospital in St. Louis, 100% of staff reported less pain, less fatigue, and interestingly, more time to focus on other clinical duties when ColoWrap was in use.
We talked about, the benefits to the patient and the physician, but I want to talk about some of the ones that are really for the hospital, right? Like we're in a different kind of environment now. So when people come back into the hospital after a procedure, that can definitely hit the bottom line for the hospital. We're all under a lot of financial pressure. So, we are talking about a $50,000 scope, like you said at the beginning. And if they break, that can be expensive. Can we talk about, basically, some of the things that looping may result in some of these like kind of ancillary expenses or things that people might not be thinking about when they're mostly involved in the procedure and not necessarily the business side of the healthcare environment?
Absolutely. Looping is kind of like, it's the little problem that could. I mean, it affects everything related to colonoscopy. And if you start stacking up the potential costs, it's pretty significant. So one example of something people don't think about, you mentioned, is scope repair expenses. So some of the hospitals we work with have $1 million plus line item budgets annually.
I've seen them. I used to work in scope repair.
I mean, it's very expensive, right? And one of the causes of the scopes kinking and the scopes needing repair is just the torquing on the scopes and the force that you're applying. Well, that's maximized when you're trying to advance through a looping colon. And so anything that you can do to kind of reduce the looping and the need to kind of torque on the scope. And I mean, there's also some human element where it's frustrating. So here's this instrument, regardless that it's $50,000, you're less friendly to it after you just were frustrated, working through. So yeah, I mean, so the looping does play a significant role in driving scope repair expenses. It increases the need for sedation. You mentioned the ED visits. One of the Medicare measures that hospitals are actually reimbursed on is the frequency of patients coming back to the ED within 7 days of their colonoscopy. And those rates, I mean, we talk with hospitals about it. A lot of people in GI don't know it, but it's often like 1% to 2% of patients are coming back to the ED. Generally, the number one complaint at that point is nonspecific abdominal pain. Well, perforation doesn't occur frequently, but they have to work up any patient that presents with a full CT to rule out perforation, even though it's doesn't actually occur frequently. And so sometimes those expenses are not reimbursed too. So that can be a significant cost driver from looping and difficult colonoscopy that often kind of goes unrecognized too.
It's funny to think that so many patients after having colonoscopies would end up back in the ER and maybe have pain or complain of abdominal pain and have those risks. And there's one other thing I know that we're bringing this conversation, winding it down, but I want to go back to a patient benefit that I think really needs to be stated, because like you said in the beginning of this conversation, colonoscopies are the gold standard. We're having this conversation, but not trying to deter anyone from having a colonoscopy.
Not at all.
But this is the test. This is the way to diagnose and treat and find those polyps, find colon cancer, find those tumors and different things. And one of the things that you've seen with the ColoWrap is a better outcome for patients with improved polyps and adenoma detection. Can you talk about that a little bit before we move on?
Sure. Yeah. I mean, it's something that is really important. That's the reason you do. In a lot of cases, that's the reason you're performing colonoscopy. And so what we found early on, when we did the studies, was that we decided to leave the device applied for the withdrawal period, even though initially we thought, well, it's really for the insertion phase to prevent looping. But what we found is that in patient groups that tended to be more difficult procedures, there was significantly improved polyp and adenoma detection. And so what the thinking is there's really kind of two avenues that explain it. One is, and I guess they're kind of related to the same thing, but if you're getting to the cecum with less loop, when you start pulling the scope back, the scope is less likely to kind of flip back and come out of the colon in a large portion quickly. You're able to do the withdrawal in a more controlled fashion. And so some of the doctors that we've worked with, their thinking is that, okay, I'm able to get to the cecum with less looping, and because of the way that the device is still applied, I'm able to perform the withdrawal in a more controlled fashion. And that's why they think that they're finding more polyps and adenomas when the device is used. The really neat thing is that when we dug into the data even more, that benefit was particularly pronounced in the right side of the colon, which is where polyps and adenomas tend to be more difficult to find and also more likely to progress to cancer. So that was really neat.
That is really fascinating.
Yeah. And I mean, just to share like some of the more rewarding procedures that when we're in and we're doing training, like there are some little tips and tricks with the device that we teach where, the doctor will have the scope just going around the hepatic flexure, and you can do this thing where you take the top secondary strap and just kind of lift it up, and it just has this way of popping the scope down in the cecum, and it's a neat thing to do. But almost inevitably, once that occurs, the physician is really able to visualize the area around the cecum really well. They have a lot of kind of control at that point. And I think that is kind of explaining why we're seeing those enhanced detection rates. So that's really encouraging. I mean, if we can help one patient find an adenoma that would otherwise be missed because they used the ColoWrap, I mean, like, hell yeah. That's why we're doing it.
Absolutely.
Yeah.
Yeah. You didn't necessarily go into it for that,
No.
but if that's there, then
Right.
I mean, you're starting to talk about the cherry on top.
Right.
All right. So we're very
well, let me
close
share
to
one
the
other
end of
story
time.
too.
Oh,
yeah,
just go for it.
real quick.
Story time with James.
The other thing that's really interesting is that patients really like how it feels, which was completely unexpected, to the extent that patients will sometimes ask to bring it home. And so I worked with a surgeon in Minnesota, a really awesome surgeon, a great guy. And this was a facility it was a small town, and they just built a YMCA right next to the hospital. And so I had reached out to the surgeon after they started using the product, and I said, "Hey doctor, how's it going with things?" And he was kind of soft spoken, but he said, "Did you see our YMCA?" And I said, yeah, it's awesome. I was there. And he goes, "Well, I work out there." And I thought, okay, where are you going with this? And he goes, "Well, I was over there working out yesterday morning, I did cases and saw one of my patients on the treadmill." And I'm like, okay. And he was like, he was wearing his ColoWrap. He's like, "You guys are getting some free advertising there." So I was like, all right,
whatever.
Yeah. But that was another kind of unexpected outcome.
Yeah.
But we're just really grateful to be at this point and believe in the ColoWrap immensely. It's a tool. It's a technology that should be in any place where they're performing colonoscopy. And, as a company, we're extraordinarily committed to seeing, realizing that vision, because it really helps people. It helps not only the patients, but it helps the people doing the procedure. Right. And this is a time, keep in mind, where, it's scary the extent to which, we're hearing about patients in their late 30s and early 40s being diagnosed with stage 3 colon cancer. It's not going away, the need for colonoscopy. And so we need to support the people and the infrastructure that are really performing this procedure. And, we feel strongly that ColoWrap can play a big role in that. So that's kind of my pitch too, to folks listening that may want to be a part of this mission and help us do that. Reach out. I mean, if that's something you're passionate about and endoscopy and you know these procedures, that's what we're about too. So sorry. I don't know.
Like a different
career
opportunity. You said you have nurses on staff. I think that's
absolutely
awesome. I've got two more things I want you to mention, but I am going to just, while you're, kind of putting it out there, they can go to www.colowrap, that's COLOWRAP.com/first case. And you could put in your phone and email address and somebody will reach out to you. So like James just said, if you're looking for a different career opportunity and this is something that you're passionate about, definitely give them a call. Or, if you're at the hospital and you have not used the ColoWrap and you definitely want to get maybe an assessment, same thing, just go to colowrap.com/first case. You can also request a track it packet, but I can't tell you what that is until we hit this last point here before we wrap up. And I don't know how to segue from great stories about the YMCA to technology and data tracking, but I'm going to try to do it. And it's just going to be straightforward. Tell me about ColoWrap 360.
Yeah. So ColoWrap 360 is a software tool we've developed that takes anonymized colonoscopy data from your facility and finds patterns and trends that are associated with your more difficult, higher risk procedures. And really what comes out of the tool, it's essentially a recipe for what patients to target with ColoWrap in order to maximize your injury prevention, your time savings, your time reduction, and ultimately your dollars saved. And from the financial perspective, the ROI on your ColoWrap investment. The Track It packet is essentially the nickname we've given to the first part of the ColoWrap 360 process, which is data collection. So this is something that is just, it's a physical manifestation. It's really just a packet of forms, and we've sometimes given them out at conferences or even ship it in the mail, but it has everything in it that you need to start tracking your colonoscopy data. And it's basically an easy way to get started with data collection and build momentum towards a customized report and ultimately a customized implementation of ColoWrap.
All right. The Track It packet. I love it. And so if this conversation hasn't convinced you that you either need to, learn more or reach out and get your Track It packet, we are going to have a link in the write-up for this episode. It's a case study about how Barnes-Jewish West County Hospital significantly minimized manual pressure and repositioning while 100% of the staff reported a reduction in musculoskeletal pain. Again, that link is going to be in the description for this episode. Make sure you check it out. Make sure you go to colowrap.com/first case, enter your phone number and email address. Somebody is going to reach out to you. They can do a ColoWrap colonoscopy assessment, get you the Track It packet. And as James mentioned, always looking for people passionate in this area. So maybe you're one of the nurses listening to this and you're looking for a different career opportunity. You can also go ahead and reach out to them at colowrap.com/first case. James, thanks so much for joining us. What a great way to take a family affair and turn it into a business, especially, you found a way into the entrepreneurial world very quickly, and you got to do something that not only you cared about, but something that your entire family cared about. Your story is really, really interesting and enjoyable, and I'm glad we had you on the show today.
Yeah, it was a real privilege. I talk about this as long as you'd want, and thank you very much.
Absolutely. Thank you.
That was James Hathorne, CEO and founder at ColoWrap, talking about their anti-looping compression device. And honestly, Melanie, so many different implications for something that it really seems like it's such a simple kind of fix, but for something that wasn't easy to fix or solve. And I think just one of the things that we've talked about a lot on a lot of these conversations with new technologies that have come into play is really guiding the R&D, the research and the development by a clinician, by the folks that are actually doing the job. And, he got all the feedback I'm sure that he could possibly want and honest feedback, from his mom. And so I just love this family business solving a problem, coming together. There's so many themes that came out today, not just cost savings and, ergonomic benefits to nurses and physicians, but, to the patient. I mean, they really hit just about every single area of concern, running a healthcare, hospital or a GI clinic that you could think of.
Yeah, I really do think they did. And I think they thought about it from every single angle. And to think that the way that the colo wrap was designed is to actually kind of mimic those hands that are doing all that pressure, but do it in a controlled and appropriate manner so that it can be location specific pressure that's applied like it should be. And it's not the nurse or the tech standing over the patient, like you said, doing a Superman or some other kind of terrible pose to put pressure on that patient and all of the risks that are associated to both the staff and the patient when that happens. So I really do like the idea and the design and the thought that went into this product in making sure that it was safe for the patient, but also took care of an issue as well for the staff and solved that for them.
All right. And shorten the time. I mean, everybody, turnaround time is important. So colowrap.com, first case. That's where you go to enter your phone number and email address, and they'll reach out to you and do that assessment for you, send you the track it packet. I love that. And you can also make sure that you go ahead and read the case study that we have linked in the description for this podcast. Great episode. Thanks to James for joining us. And on behalf of Melanie and myself, appreciate everybody listening to this vendor spotlight on First Case.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.